have a good break? Good. All right, so today is going to be a very practical day. We don't have a rat or anything like that. And last year, this class was actually combined with Dr. Sharpton's. I don't know if she told you that. So she gave you guys med adherence Monday, maybe? Does that sound familiar? Okay. I got some blank stares right as I said that. And I'm like, I know she taught you guys on Monday. So she and I did this class as a combination class last year. It was med adherence and heart failure assessment. And next year, we'll probably do a more comprehensive cardiovascular assessment. But for that reason, we may not necessarily need the entire class time to do this. But what I will say before I even get started is that as you guys are working through this is osceoable/skills assessment type material today. So just as you're practicing with your partners in your group, just be cognizant of that, because I'm not going to be hawk-eyeing everybody, but take it seriously and work through the role plays and make sure that you really understand how to check the heart rate and the breath sounds and things like that. And I'll be walking around if you have any questions about placement. So this is just all kind of practice today. The other part to this is that as you're speaking with patients and you're doing some type of physical assessment, you just always want to be very intentional about how you approach that. And so one of my biggest pet peeves, which happened to me at my wellness visit the other day, the nurse practitioner says, all right, I'm going to check your respiratory rate, breathe normally. And I'm like, okay, breathe normally. Like, who doesn't think about that? So one of the kind of pearls that I tell people when you're checking the respiratory rate is check the heart rate for 30 seconds and then discreetly check the respiratory rate as you're still pretending, I guess, to check the heart rate. That way you get a natural breathe. Because as soon as somebody says, okay, breathe naturally, it's like, well, it's not already doing that. So that's one thing, because you're not going to get that organic assessment that you need from that. And then also be cognizant of things like a cold stethoscope. So if anybody's been to the doctor, a lot of times people will warm their stethoscopes up before you stick it on somebody's back or chest. And then making sure that you sanitize. So I have hand sanitizer here. Today is not one of those classes where I require you guys to come prepared to take off your socks and shoes like we do for our diabetes class. But that would give you a more realistic example of how to check when we do for peripheral edema. So we'll check on the shins and on the leg, and then we'll check on the foot. So if anybody takes their shoes and socks off, I do have hand sanitizer here for you to use. I don't have gloves, just hand sanitizer. And then if anybody happened to have forgotten their stethoscope and needs to borrow somebody's, I have alcohol swabs here if you want to wipe off the earpieces or something like that. All right? So that's all the preliminary stuff. All right. So these are the assessments that we're going to do today. We'll spend maybe 10 to 15 minutes on each if we need to do that. I'll kind of play the room and see where we are. But first we're going to do respiratory rate and heart rate, which, have you guys ever done that practically before? So that should be a review. So we may not spend as much time on that. And then we will get into peripheral edema, breath sounds. We'll do capillary refill and skin Turgor maybe together, because those two don't take very long. And then just a review of heart sounds. So did Dr. Snella go through, have you guys done EKG and heart sounds with Dr. Snella yet?
Not really.
Okay. And then we have a couple of patient assessment role plays that I'm going to do. So hopefully there's enough people to at least pair up. If not, we may have to do a trio on one. But what you'll do is you'll interview your patient as if it's kind of like a patient scenario, and then do whatever physical assessments need to be done for that patient. And then that'll be it for today. All right. So the first thing, as you guys are probably aware, this one should be a repeat, like we said, but taking a pulse. And so two of the main places that you can take the pulse are on the wrist. Of course, it needs to be on the thumb side. So make sure that you're being aware of that. And make sure that you can actually feel the pulse, because people will fake it till they make it all the time, and they're not actually getting the pulse. So make sure that you can feel the pulse on the thumb side. Don't ever use your thumb, because then you're getting that interference of potentially your pulse interfering with the patient's pulse. And so usually use that first and second finger and press firmly but gently, as it says, on the artery there in the wrist. So sorry, I'm kind of under the weather today, guys, so I'm gonna try to get it together. I know you guys can hear it in my voice, but I'm gonna pull it together and pull through. And then, so usually I count for 30 seconds. You can do 60 seconds, but you'll count for 30 seconds and then multiply by 2 for the pulse. That's usually the easiest thing for me. And then I can discreetly check the respiratory rate for that remainder of the 30 seconds. So as I put on the slide, discreetly monitor chest and check respirations for 30 seconds and then multiply that by 2. In your notes, at the end, I have a couple of documentation forms. I don't know if you guys got that far down. And so if you see those, that's kind of what will be used if this is on a skills assessment or OSCE. That's where you'll be having to, that's the kind of form, exact form that I would give you to document the patient's information. And so in terms of documentation, if the patient's heart rate is 68 BPMs, of course you know the acronyms at this point. Respiratory rates are also BPMs, breaths per minute. Sometimes people just write out breaths per minute, just so that there's no confusion there. And then I put in parentheses the reference ranges for those. So a normal heart rate is about 60 to 100, and a normal respiratory rate is about 12 to 20. And so when you're looking for the respiratory rate, another thing, just look for that slow kind of, I guess it's deliberate rise and fall in the chest. Again, you guys have done this one, so it shouldn't be too difficult. But just take maybe about 5 minutes or so and just review and practice this on a partner. If you're at a table where you don't necessarily have to be in your teams today for anything, team assignment, so if there's a lot of odd numbers, we can pair up some kind of way instead of having a bunch of threes. So it looks like this table may need an extra person if there's an extra somewhere. Yeah, y'all 2 tables, right? Yeah, that works. All right, so take about 5 minutes and practice the heart rate and respiratory rate on your partners. And then we'll move on to Edema.
Come on, bro. Get your shoes and socks off.
Shoes and socks off? You really want me to? Oh, I have a question. Did you understand the skin Turgor test where they were pushing down?
Oh, that's tough.
Yeah, the pitting edema, but is it when they let off and it stays down that much?
Yeah.
Or is it, okay,
And there's an amount of time.
because that picture was weird.
Yeah.
It didn't show them letting off. So
And it shows the finger still there.
I was like, you can press hard and get some pitting edema on someone if you really tried, but yeah.
All right, ready?
Yeah. Mine's probably high. It's my heart rate.
Just relax.
Stop watch.
Or do you want to sit? Just put it rest. Like if you were about doing breathing, You get it on that? You're discreetly watching my breathing.
It's so faint. It's really faint. I feel bad.
10 respiration.
A minute?
And 88 beats per minute.
Oh no, respiratory depression.
You feel it good, man. I don't have to.
Okay.
Okay, so
Yeah.
while you guys are doing
A
that,
pretty strong pulse.
we're going to do a demonstration. Dr. Sharps and I did this last year, so I didn't really have a plan for it this year, but I'll use you guys instead. So she's asking about the transition between checking the heart rate and then going into the respiratory rate and how to do that without seeming kind of awkward or anything like that. So I'm just going to do a quick demonstration with her really quickly so you guys can kind of see. I mean, it's kind of weird, but as a patient sitting in the room, you just expect that the physician or the nurse practitioner or the pharmacist in our case is just doing whatever it is that they need to do. So you wouldn't question it too much. All right. All right, so thank you for... Oh, I thought it was something up here. So, okay, so thank you for allowing me always ask for permission before you start patient. Okay, so first I'm gonna check your pulse. And so I'm gonna take my fingers here on the inside near her thumb, and I press down kind of firmly so I can really feel it. And so as I'm doing this, let's just pretend 30 seconds has gone by. I'm already kind of facing her in this position anyway, and so I can see her chest from the angle where I am. So I'm not really like just staring at her chest. I'm just kind of slowly, you know. I guess it's subtle. I don't know. But you guys know what I'm doing, so yeah. Now she's altered her breathing because she knows what I'm doing. But in the midst of it, you just kind of, I can still feel her pulse this entire time. And I just transitioned from counting my pulses to counting her respiratory rate. And you can kind of do that discreetly. As you guys, like as a patient, we typically know that they're probably going to do the respirations and the heart rate simultaneously or right one after the other. But a lay person doesn't always know that, so they're not like, wait, what is she doing? Why is she standing on my chest? And so, I mean, it's really up to you, honestly, if you want to announce it that you're going to check their respiratory rate and tell them to breathe normally. I just personally think that automatically makes the person breathe accurately. So, anyway. So, has everybody in a couple more minutes?
There it is. This is 82.
82? Okay.
That's good. I wish I had my watch. It'd be a lot seamless. Okay, pretend I'm still taking your.
Oh, and then I started laughing.
14?
That's good. You're normal. I'm subnormal. I think the reason I'm probably like too short is because my septum is deviated. So I'll probably breathe slower because of that.
Oh.
Because I have one nostril. Maybe if I was breathing out my mouth, I'd probably be like. You know? I always get afraid when I go to the doctor and he's taking my breath sounds that if I take a deep breath, he might hear like my nose making noise instead of my lungs and then think I'm wheezing or something. Did y'all do heart rate on blood pressure that day? 'Cause I wasn't there that day.
Yeah, we did.
Y'all did heart rate? Okay.
But we did it like you put your hand.
On them?
Yeah.
And you listen to it at the same time?
No.
Or
Okay. I put my. You mean your wrist?
yeah.
I put like this. So every time you push against me, you're breathing.
Okay. Like in that video?
Yeah.
Okay. That's kind of
All right,
hard
do
to
we have
do. I don't know.
any questions
I just do it for a minute.
about heart rate and respiratory rate?
Like
30 and 30.
that'd be a lot less awkward, but
Appreciate
if
it.
they notice you're
Was
looking at
everybody
their
able to
chest instead of
feel
their
the
watch,
actual
they're gonna be
pulse,
like,
or anybody have problems on their partner? Everybody felt it. Everybody's sure. Okay. We don't make up numbers. Okay, so the next thing is breath sounds. And so I guess I'll have another volunteer come up so we can do this. But for the breath sounds, you want to make sure that you listen to see if there's. Everybody ready? Listen to see if there's anything in the patient's lungs, especially for heart failure. If you're listening for crackles and rails, things like that can be signs of infection. It can also be a sign of fluid buildup in the lungs. So that's the reason why we actually listen to the lung sounds. And you're going to do that with the diaphragm part of your stethoscope. And so last year I had a problem with people not knowing how to open and close their diaphragm. So I'll come around to make sure everybody actually has the diaphragm open and not the bell, so that you can actually hear on your stethoscope. So what we'll be watching for in this phase is that you at least hit, I can't remember what I told them last year. There's 9 points on the back that you should be hitting. So I really want everybody to do that. But as long as you do 4 to 5 of those, you should be able to get a significant amount of information from the lungs. So it's just recommended that you hit all 9 of these points. But most of the time, people will hit maybe 4 per side, and then you must also get the laterals. So listening to the lungs and the lateral will give you a different perspective than just listening to the lungs on the back side. So if I could have anybody come up, I guess. Since I'm up here, I'll just grab somebody from the front table. Do you mind being my volunteer, please? Yeah, just come stand right here. Your part's easy. Okay.
Take the jacket off.
All right. So, side note, that was funny because that reminded me of my fiance yesterday. We had engagement photos, and the photographer's like, "Do this," and he's like, "I'm like, no, like she's telling you to do, like this is easy. What are you doing?" Like, anyway, guys.
Guys can't take
I know,
photos.
guys. All right, so he's got on a jacket, which this is not a really thick jacket, but if you have on a patient with a thick sweater in the wintertime especially, you may want to have them remove that so that you can get a better, so that you can hear better on the lungs. But this shouldn't be a big deal for him. So making sure that everybody puts their stethoscope on correctly. And then what I usually tell patients to do, normally the patient will be sitting down, but he's not, but I'll still tell him lean forward slightly. That way you kind of open up the lung and the breath sounds. If the patient's sitting straight up and closed off, that could be an obstruction itself on the breathing. So you want to have them lean forward slightly, and then you'll start your examination. And so as you can see on the diagram that I put on the slide, you definitely want to start up here. So starting up here allows you to get the full gamut of the lungs. So here, we know that the lungs are primarily kind of in this area, but you can also hear some wheezing and crackling sometimes here in the upper lobes of the lungs. So you want to start further up here. And I also recommend that you kind of go in a zigzag pattern. That way you can tell if it's similar bilaterally. So I may say, I hear nothing here. Oh, I hear something here. And it may be a unilateral rails in the right upper quadrant of the lungs or something like that. So make sure that you go in a zigzag pattern. So I usually start from top to bottom. For me, that's usually easier. I don't know anybody that does it differently. I'm not the physical exam expert, but that's what I was taught, and that works for me. So again, make sure that your diaphragm is open so you can see on your stethoscope the bell side should be closed here, and so that just means that your diaphragm is open and you can twist this to open the bell. All right, so I'm going to go from one side and I'll tell him to breathe in, breath. So I'll just keep going like this all the way down the lung field and have to do a deep breath. Just like that. And then once I get to my final, I will make sure that I get right underneath here for to hear the lateral breath sounds. Okay? documentation, lungs, the CTAB, clear to auscultation bilaterally. I don't think that's new terminology for you guys, and then no RRW is not, rail bronchi or wheezing. And I think I put a link in your notes as well, if you guys want to refer back to that. We won't play it in class today, it's just kind of for your reference, so that you can hear what rails and bronchi and wheezing sounds like. I've heard it on the tape before. I've never actually heard rails or bronchi on a patient. I have heard wheezing, and you can really tell. So if you only hear like this blowing, like, that's normal. But if you start to hear like screeching that I can't even do right now because my throat's not well, then you'll be able to tell, is my point. Because it's really hard sometimes to put things into perspective until you've heard the abnormal and compare that to the normal. So just go through and listen to the lung sounds on your partner, have them lean forward, and if your stethoscope is coming on.
You 16? You can have the lung problems. I want to hear your lung. Well, I'll wait. I'll see if she hears. Yeah, towards the front.
Oh, girl, you scared me. I don't know. I just expect you to. Look. So this way.
Yeah, towards the front. It should be towards the front.
This way.
Yeah. I didn't see how she had hers on. All right, Bryce.
This chair's kind of make this weird.
Sit up straight, lean forward slightly. Take a deep breath.
Yeah. Breathe in. Did you breathe out? No. Okay. Breathe in. Go in that corner, way over there. Don't be in the thing. No. Yeah.
That's clear.
Get him? That's
Yeah,
good.
you can hear it.
Did you hear any wheezing or anything or stroke? No. That's good. It is just my nose, man. I feel like I'm like. That's good.
You can hear mine?
Yeah. If I can with these cheap ones.
Huh?
If I can with these cheap ones.
It's all right.
It was so And then when you start moving further down, it's still here. The last time I walked
I need any
Okay.
I want to call him Advent.
Yeah.
Yeah, I heard that the district couple. A lot of ones are hard to do.
Yeah.
But
You gotta come like.
it all sounded good. I mean, I didn't hear nothing weird. Which is good. The best sound I heard was, well, she put it down, but it was 3.
Oh.
3
okay.
was the loudest one. I was like,
I think I just did 5.
I went to 3 and was like, whoa. This stethoscope kind of sucks too. Like when I was pulling it off of you, I could hear everyone talking, and I was
Oh,
like,
yeah.
oh.
Let me see.
Yeah. Go for it. It doesn't have like a, it's not expensive at all. It was like maybe $10.
Doesn't your girlfriend use them?
She uses nice ones.
And she's a nurse too.
She uses Littman. Actually, didn't even realize my diaphragm did this. I guess I didn't have a monster yet. We can check my
Yeah,
heart
heart
rate.
rate.
Would have been like really high.
All right, was everybody able to hear the breaths? Kind of. So, just because I got asked a couple questions throughout, I decided to go ahead and pull this up. But again, this link is in your pre-reading document. But just so you guys can hear kind of some abnormal sounds, crackles or coarse rails is one thing that you might hear. So let's. So you see how it's not that normal, like wind blowing sounds.
All that nicotine.
Another common one.
Why no real?
Wheezes. Let's see.
Yeah,
Let's do
pneumonia.
expiratory wheeze.
Sounds like a whale.
So it kind of sounds like a horn or a whistle.
Orcas.
Yeah. I want to hear some rails. That sounds a lot like,
That's Free Willy.
yeah.
You guys hear that? Okay. She's like, that's cool, unless you're the patient and you can't breathe.
Strike.
Bronchi, and then yeah, because I let you hear rail. So
Oh, is that what rails are?
bronchi, kind of low pitch wheezes here.
Pretty sure that's heart failure.
So that's just a few examples. This one has pretty much all of them. Strider, which is one that I've never heard from an actual patient.
It's not in my book.
It's awful.
Sounds like when you're hungry.
So that's gonna be you'll know if it's something that's not normal. So you should just be able to hear a smooth breeze in the lungs. Everything should be flowing nicely. If anything is obstructing, like with COPD, or if a patient has asthma, you might hear some wheezing. If a patient has fluid in their lungs, you might hear some bronchi because there's something obstructing the lungs and the air from getting to where it needs to go. So you'll be able to tell the differences. So there's a ton of them here. So if you ever need a reference, this is just one site. I'm sure you could YouTube and find others as well. All right, anybody have questions about the breath sounds? So takeaway points as far as listening, make sure that your stethoscope is turned appropriately. Another pearl that you don't have to do, but I may have listed in some of your documents. Once you get over to the lateral areas of the lungs when you're listening, you can turn it over to flip it over to the bell side and switch that, flip that switch. And sometimes that will allow you to hear some of the higher pitch sounds in the lateral areas. It's usually not absolutely necessary. If you have a patient that you're suspecting something's happening and you want to double check and make sure, those are usually the times that I recommend it. But on a normal breath exam, if everything sounds okay, if you can clearly tell that the patient has bronchi or wheezing throughout the breath field, then you don't necessarily have to turn it over to the bell side once you get down to the lateral areas. But make sure that you hit preferably all 9 of those areas, but for sure at least 5 areas of breath sounds on the lungs. Okay, the next thing we're going to do is pitting edema. And I'll pull up some pictures of this as well while you guys are practicing. So we mentioned this in class, but oftentimes patients with heart failure will have edema, right? And a lot of times that edema will be bilaterally in the lower extremities, which is pretty much the legs and the feet. So you can kind of see it's kind of subjective because 1 plus mild pitting edema is 2 millimeter depression that disappears rapidly. But nobody ever has a measuring tool to say that's exactly 2 millimeters or 3. So you kind of have to use your clinical judgment and once you see it often. And I mostly look for how quickly does the skin go back to normal. So once you depress it, does it come back rapidly? Does it take 10 seconds? Does it take a minute? Which patients with severe pitting edema, it may take 30 seconds, a minute for their skin to bounce back to where it was. So it's going to be very difficult for you guys to tell on each other today because most people walking around normally won't have any moderate or severe pitting edema. So I'll pull up some examples of that for the whole class to see. But as you're going through, what I recommend is to press either the thumb or the first two fingers. And I usually do my first 2 fingers just because it's easier for me. And you'll do that usually on the around the shin and then on the top of the foot. So this one's hard to demonstrate because I can't put somebody up on top of something and show you guys. But I'll walk around while you're doing it. So you want to make sure that you're doing on the shin, like right on the outsides of the shin, and then on the top of the foot. And so I just have to walk around and make sure that everybody's doing it correctly. I also recommend that you do at least 2 to 3 areas or at least 2 areas on the leg, and then you must do the top of the foot is like a must. So if you neglect to do the patient's foot, then that's going to be a count off for that, because oftentimes patients may not have as much edema in their legs, but it may be accumulating more so in their feet. So you definitely want to make sure that you check that. As far as documentation goes, depending on how much you think the patient is pitting, you can put +2 or +3 pitting edema bilaterally or unilaterally on the left side, bilateral lower extremity edema +2, either one of those is appropriate, as long as you have what the criteria is, +2, +3, is it bilateral or unilateral, and then the fact that it's edema. For most conditions, it's going to be bilateral, just because the patient's lymphatic and circulatory system is messing up the entire gambit of the person's body. Some places where it may be unilateral is if the patient has had some type of physical injury. So I sprained my ankle playing softball. I may have some edema there, fluid buildup. That's probably not a cardiovascular or a systemic issue. That's a localized issue. Every now and then, patients that are having a DVT may have some edema, and typically that DVT, of course, is unilateral, and so that edema may only be on that one side. But for patients with severe edema due to some type of circulatory issue, it's going to be bilateral. All right, questions about how to actually do it? Like I said, I'll walk around and make sure everybody's doing it right. I have hand sanitizer up here if you need it. Otherwise, all right.
Oh my gosh, this electric was gonna suck.
Bryce, did you get a pedicure done? But I'm not touching Cal's feet.
You got anything about feet, Alex?
Huh?
You said you got an aversion to feet.
I don't have weird feet. I don't think. At least I don't think.
Let me see your shin.
Shin? Do my right leg.
Oh, now you want to after you touch it?
Well, I can feel it.
Before and after.
After, that's the most important.
Should shave my legs first. Keep here.
Oh, man, look at that.
Oh, that's. Oh.
Yeah, so this guy's is really bad. Yeah, there's no rebound, so that lets you know that there's a ton of fluid buildup in his periphery, and it's gonna take probably about a minute or so, at least 30 to 45 seconds for his skin to kind of bounce back into place. So hopefully nobody in here has severe.
Oh, you're good.
I don't know who about it.
What? That was bad.
You good? You got the good one?
Where do you push it? Is there anywhere special?
Shin is shin.
Is there a special size? Because I know there's a bony part of the shin right here. That's not going to do anything for most people. You have to.
Well, they were touching him like this.
Yeah, on this side.
Yeah.
That's the non-bony side.
What happened?
Oh, we read it.
Hold it down.
We read it.
Okay, good. I was worried. Did y'all listen to lungs? I know she had that thing.
To the ankle?
Okay, so what is it? It's just up here. What were the five things that she was saying?
You have to go 9, you have to go.
1, 2,
You have to go by that. Yeah. And then come down.
Okay.
Go over. And then go all the way down the back. And then you have to check for the lateral. The lateral.
Dr. Wallace?
Check around the ankle as well. So I would do on each side of the shin
Each side.
once, and then maybe down the ankle. So that kind of goes into the leg, I guess, on each side, and then at least the top of the foot. So those are kind of your three main areas.
Do you just depress and let go?
Yeah, so like if I'm checking edema, I'm going to press down for a couple seconds.
Okay, couple seconds.
Yeah, okay.
Easy.
Yeah, you bounce right back up.
I may have
I know everybody else.
5 seconds, 3 to 5 seconds, I think is what I have on the slide.
Okay.
Gosh, they give us so much reading.
Alex, you might have started a trend with your lipids.
Yeah.
Everybody
Those are
might go.
super, super good ones.
Yeah, they are.
It says 5 to 15.
Yeah, that's too long. I mean, I did 10,
Oh, we put
which
0
is
plus.
still in that range. I feel like 15 is a little excessive.
Oh, yours is blue. You
Yeah,
ordered blue?
5. Oh yeah, I got the fancy one. had to get me a little color.
Where did you
match
get
my
that?
scrubs. I ordered it on Amazon.
How much was it expensive?
Well, you had
It was
to
about,
spend
I
10
think the colored one was 80. I think that one was about 70. So it's really not that bad.
My girlfriend got a lip mint, and it was has custom engraved with her name on it and stuff. It's like $150.
Yeah.
But she uses that all the time.
And see, we're not going to be in that situation. Where we use it
They like
Otherwise, I would have bought a really great one.
they drop theirs and like step on it. And yeah, they drag those things through hell. The nurses have to be careful because some nurses will steal stethoscopes sometimes.
I can believe that.
They'll sell them.
I
Yeah.
can believe that. There's some good money in these things.
You ready for lecture?
I stayed up until 2 o'clock last night reading for this grade. So
Oh my God.
that I am ready and that I make a good grade because if not, I give up on life.
I have not read a single word of anything.
Oh my
Yeah.
gosh. Yeah, no, I spent some time. After I got my test score back, I was like, oh,
And you're like,
I
ah.
really
be up
need
tonight.
to focus in. So, yeah, I stayed up until 2 o'clock last night trying to get through all, and I still didn't finish.
So I was asked the question about how long to
Too
press
much.
down. I was telling them I usually press down for about 3 seconds. I put 5 to 15 seconds. I think is probably what the reference says to do, but it just at least 5 seconds to give you a good idea. 3 to 5, I wouldn't count off if you did 3 seconds. So as long as you're pressing down long enough to actually tell if there's an indentation that's going to occur. Okay, so I think I'm going to call up somebody because I really want to show everybody where to do this. So can I have a guy that has on loose leg pants that can hold their leg up? Or maybe
Here you
10
go,
seconds?
Bryce. Just lift it on
I'm too hairy to see anything.
up. Turn over on your side, you know.
Sure, thank you. I appreciate
He
that.
might have hairy legs
Oh,
too.
yeah, you go have everybody.
Yeah, never mind.
So he's here. Everybody kind of see.
Raise your leg up.
Up
Raise your
high.
leg.
Up there.
Real high.
You me too, I'll
There
flexible.
you go. Manly pose.
Those some soft
Okay, so
legs.
if I'm checking for edema on his leg, what I would typically do is check on either side of the tibia. So I'm going to check here, press down for 3 to 5 seconds, and then check here. Oh, sorry. So press down for 3 to 5 seconds, and then I'll check on either side of the ankle for 3 to 5 seconds, and then I'll check on the top of the foot right here. So he doesn't have any edema; it's really bony. But for a patient that does, it's supposed to be a joke. But for a person that does have edema, you'll be able to see.
You'll be able to
on the
tell.
top of the foot. So still check there, just in case. Okay. So that's just for identification purposes. Thank you. All right. Other questions about where to check, how to check for?
What is it like? Cap?
All right. Have you guys have done
Check both.
heart sounds or no?
Because it could be unilateral.
You didn't talk about where they are, just kind of what they are? Okay. So for the heart, you want to make sure that you're checking in all 5 of these places. So just keep in mind that these 5 places are necessary for you to check just because they each have a different purpose. So you're checking the aortic valve, you're checking the pulmonic valve, the second pulmonic valve, tricuspid, and the mitral. And once you get all the way through here, so I'm going to make sure that I check the heart here, 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 here. Once I get down to the apex of the heart, I'm going to flip over to my bell side, and I'm going to go back up and check all these fills again. So, and that's just because there are some heart sounds that you can hear, the higher pitched sounds with the bell side of the stethoscope that you can't hear with the diaphragm side of the stethoscope. And so if you see the documentation of RRR, regular rate and rhythm, for a patient with AFib, you'll start to see things like irregularly regular, things like that. Positive S1 and S2. So positive S1 and S2 just means that you can hear those sounds of the heart very clearly. You'll hear that lub-dub sound that we talk about when we talk about heart sounds. And then we won't really get into S3 and S4 for this class purposes. As long as you can hear the love dub, that's kind of the biggest deal. Some of the coolest things I've heard that don't come around very often, patients that have valves, so like mitral valves, especially some of the old ball and chain valves that they don't even use anymore, you can actually hear it clicking because it's beating the patient's heart for them. So things like that are very interesting to hear on patients. So if any things like that come up out of your rotations, it'll be very good for you guys to kind of get that experience. But anyway, so just make sure that you check all 5 of these fields and that you do so going down on the diaphragm side and back up on the bell side. Okay? If anybody feels uncomfortable checking their partner, you can switch partners or whatever you want to do for class purposes, that's fine. Okay? Questions about it before y'all start practicing? All right.
I know, like, how you gonna get to it?
What if somebody has
Your right hand.
Right hand over heart. So it's like right over here. So like middle sternum to your left.
Your left chest.
but number 1 is on the right side of the
Number
spine.
1 is on the right side, and the rest of the part is on the left.
Yeah.
Got it.
Yeah, you go 1, 2, 3, 4, and 5. And that's up underneath there. And a little lift.
I'm gonna fill this quiz today.
And sometimes it's very difficult to get the 4th and 5th heart sounds on females just because females have breasts. So, I mean, you guys are clinicians. It is what it is. Females have breasts. So that's why I said if you want to switch partners, that's fine, because it is sometimes difficult to hear that 4th, to really get the 4th and 5th sounds unless you kind of get in there.
Get in there, Hope. So right, her right side. There you go. That's your left side.
Yeah, but I'm just trying to figure out how you
So 1 and 2 are even across, yeah, and then you just go straight down.
Oh man.
I wonder how would you hear like if somebody had a pacemaker, like some kind of device.
I don't know. Maybe with the bell.
That's her right side. That should be number 1.
Can you hear anything?
Number 2. One, 2, 3, 4, 5.
Like, where you going with that thing?
Did you flip it back?
I might have to actually.
Surely those don't make us do a hand right? Because it's not like these are humans.
Hold on, 1 should be like right here.
Okay, wait, I'm like,
Yeah, you should hear it on that. You're like double.
They have to. Well, you want to just practice on it? I don't know, there's too much insulation. Yeah, we're gonna practice on y'all. It's too hard to do it on us. Yes. The beat goes towards the patient. So yeah. No, that's right. You're good.
These aren't very good.
Yours don't really. Yours don't have a side. How odd. Yeah, hers are just straight across.
I couldn't hear 4 or 5.
Because they're supposed to go towards the patient.
I think that's might be.
Is there a proper way for the other ones over there? Because they're just
You
like
want to
straight
get
across. They're
use mine
not
if you want.
pointed either
I
direction.
don't know, what I would do is put them in.
Yeah, I'll do that.
Just tell them, can you hear me?
Because I think when I was moving around
Yeah.
on this, I couldn't hear anything.
That's your final chance.
Yeah, if y'all don't mind. It's just, it's too hard to hear on this.
Yours is a good one. I can't hear that. It's just me. I mean, I believe your ears are clean. Oh, wow, these are nice.
I'm out. 5 is more.
Oh, there it is.
Yeah,
I
keep
hear your
going back all
ventricle.
the way back.
That was weird. That was a strong
Go
thing.
back.
Oh, to.
You gotta reverse forward.
Oh.
They may be really faint because it's only high pitch.
I'm trying to do it. You work back the back.
Yeah,
Want me to turn around? I actually need to all the way 55.
Really faint.
Yeah.
Almost
All
thinking
right,
of
was
tricking
everybody
myself into
able to
hearing it.
hear some sounds?
That was really good though.
So we were talking, two things that came up about, one, the the fourth and fifth space, so hearing sounds in those spaces, especially on the bell side. So typically you shouldn't hear anything. That's why I didn't make a big point to bring it up. Those are usually sounds that you hear when something is wrong. So when I flip my stethoscope over to the bell side and I check the apex and then I check by the tricuspid valve, if there's some type of defect in those valves or if they're not closing properly or something like that, usually you'll hear those sounds. Otherwise, the bell side is meant to pick up those more high-pitched type sounds, and so otherwise you won't hear anything, or you shouldn't hear anything. So that's something that you can kind of, in your own time, just YouTube what those sounds like, the S4 and S5 spaces, what that sounds like. But yeah, so you shouldn't really hear anything on your patients in that area. So as far as documentation, that's why we usually put positive S1 and S2, because I should be able to hear the left up sounds. If not, something's really wrong. I shouldn't hear any murmurs, rubs, or gallops, which again, just like with the breath sounds, that's something that you can look up and really hear the murmur or the rub or the gallop. And I shouldn't hear any S3 or S4, so they would document absence of S3 and S4 sounds. Or if they do hear something, they would document positive S3 and S4 sounds. Okay?
The S3 and the S4 sound, is this something you hear between the S1 and S2 or something you hear like?
It's something that you typically hear. So S1, S2, S3, S4 is more so in relation to the rhythm, not necessarily these spaces. So the S3 and S4 sounds are typically heard closer to the base of the heart or the apex of the heart and near the tricuspid valve is where you typically would hear those sounds. But it's more so in relation to the rhythm of the heartbeat, which I can't eloquently explain to you. Physiology people probably could, but yeah, so that's more so what that's related to. Other questions? Yeah.
What if the patient has some kind of device, like a pacemaker or something?
Yeah, so if a patient has a pacemaker, sometimes you can hear that. You would need to probably know that going into it. If not, depending on the pacemaker, sometimes you can hear it, just like I was saying with some of the valves. Like I can hear the ticking. Like you can actually hear it in there, like a clock actually pumping their heart or regulating their heart for them. So sometimes you can hear that. In that case, as far as like heart rate goes, all those things are dependent on that valve or that pacemaker. So you, as a clinician, you would know that the patient has this device and you would just document accordingly. But other than that, I mean, you still might be able to hear some abnormal sounds in the apex maybe, but I've never personally heard them. So I'm not 100% sure. But that doesn't change the way that you assess the patient. You still assess the patient the same way. All right, other questions? All right, the last two things we're gonna do at the same time because they're both fairly quick. And so we're gonna do capillary refill and skin turgor. And so we look at capillary refill for a couple of reasons. One is dehydration, another one is blood flow. So if a patient is dehydrated, oftentimes for skin turgor and for capillary refill, the times are gonna be slow for that. The patient's skin is gonna be really dry, and they're also not going to be perfusing the way that they normally would. And then also so blood flow is kind of the perfusion part of it. So really you should see a good pink color. So if ladies have on fingernail polish, you really won't be able to see it. Another place that you could check would be on the toenails if you need to. So this one's kind of hard to do if patients don't have clear fingers for you to kind of see that capillary refill. So what you're going to do is have the patient extend their hands out to the level of their heart. So if I'm assessing a patient, I may say, okay, do you mind holding your hands out for me? And then I would just take a couple of fingers, press down, a couple of seconds, and release. And you should be able to immediately see the blood rush back to that area. Once you've displaced it, it should come right back. Yeah, if it takes a few seconds to come back or more than a few seconds to come back, that usually means there's some type of constriction, the patient's not able to perfuse properly, or there's reduced blood flow to that area, which could be indicative of cardiac issues, because we know patients with heart failure have a hard time a lot of times constricting systolic or filling diastolic heart failure blood and circulating that throughout the body. So for documentation purposes, you would just state that capillary refill is less than 2 seconds. That would be normal for most patients. It should come back almost instantaneously. And then the other one is the skin turgor. So this one is really, to me, a real true representation of dehydration, especially for patients with severe dehydration. So for patients with heart failure, this usually isn't going to be an issue because most of the time they're going to have fluid overload. But this is something you still want to check for, just so that you can rule out other potential causes of ailments for the patient. Patients that have severe vomiting or diarrhea may be losing a lot of their fluids, may have poor skin turgor intermittently. And so two of the best places to check for, I have a few places on here that are reliable, but two of the best places to check are the upper chest right below the clavicle, so like right here, right below the clavicle, and you pinch that skin up and let it go. The back of the hand, like you see on the picture, so you're literally just pinching the skin up on the back of the hand. The forehead, I've never done the forehead on the patient. It's a good place to check, but it's just kind of an odd place to check for patients. So I usually stick with the clavicle or upper chest below the clavicle in the back of the hand. You can also do the forearm, so you can check here to see. And that's a common place as well. So any four of those places would be reliable. I would recommend checking in at least 2 of the 4 to get a true representation of the patient's skin recoil. And so I've given you some examples here. Skin coil about 3 seconds at the clavicle. Non-tinting would be kind of a documentation. So by tinting, it's kind of self-explanatory, but you can see how this patient has some poor skin turgor because the skin is literally tinted up. And it'll take a while for that skin to go back just because they're so dry that they don't have any hydration to help refill or replace that skin that's been pinched up. You'll see this a lot in your elderly patients, and then again, your patients that have dehydration. Okay. All right, questions about how to do that? So these two are pretty quick assessments that can give you a good bit of detail about how the patient's perfusing and how much fluid they have. So go ahead and practice these real quick, and then after these, we'll go through one. I think there's one other slide, then we'll take a break. All right.
You check my forehead. My little bump right here.
I won't lie, if someone did that to me, I was thinking they'd like be popping a pimple or something.
Ow! Ouchie!
Oh, you fine. You have to do both of them?
Good what? I'm fine. We're just getting there. Which side? Up or down?
I think it's inside form. It hurts.
Man.
It really hurt. Well, it's back in the hand. That's it. Oh, below the clavicle. Is that? Ow! Yeah. I guess here.
A good point was brought up here about people with cold extremities. So if your hands are really
Right
cold,
here where there's not.
then your perfusion time is at baseline a little bit
There's no
slower.
way.
So you can try warming the patient's hands up, rubbing them together, and then try it. But
My
just
hands will
don't
probably sweat.
misdiagnose somebody with poor reperfusion just because they have cold
And then
extremities.
your forearms didn't have any extra skin. Couldn't even grab it.
I was making weird.
Also didn't want to be like,
And for a really good assessment, the patient's hand needs to be even with the heart.
it looks like you're getting a manicure.
Oh no, I just wasn't seeing it.
Ooh.
My mom and daddy will be interested in a few hours. You know, they just, my sister gonna drive me down there. But I gotta go to my hair. So I made the appointment. So, whichever one I don't make, I just pay. And pay for the time. She was supposed to wait 10 years. So she didn't need graduation.
You're
You could say they have to come back for ladies with the edema. But the funny thing is, if you get her laptop and what they teach us, I did this, I went to school with the doctor. Because I'm telling you, this is not for kids. Because y'all don't give me a good education now. We got the calculator pen and pencil. This is wrong. It's wrong. And then they said, if the why is she on calculator? Because you calculate what to give her. I have no albumin down in here. With no albumin. They call it.
All right, everybody do okay with these two? These are pretty easy. All right, so those are the heart rate, respiratory exam, cardiac exam or heart assessment, heart sounds rather, skin turgor and capillary refill and edema. So those are the areas that you'll need to check. So when you're preparing for any type of assessments, just make sure that you go through these slides and understand how to check them, where you're checking, what the purpose of that assessment is, which I tried to put a few reasons at the beginning of each slide here. I think it's in your notes as well. And then how to document. That's one of the biggest things, is how to document what your findings are. All right, so the last slide here is about echocardiograms. And I don't know how much you guys have gotten on this, but I just wanted to put one slide in here just so that in case you haven't gotten a lot about it, you just kind of understand the purpose of it. So we already know, just based off our heart failure class, that patients will go in, they'll get an echo. The echo will generate an ejection fraction. The ejection fraction will help us to determine whether or not the patient has any type of heart failure, and if so, systolic, diastolic, and how well they are actually expelling fluid from the heart. So a normal ejection fraction is typically 60% or higher, and then you know for a patient with heart failure with reduced ejection fraction, less than 40 is what most of the guidelines determine as diagnostic, and then greater than 40, oftentimes those patients have preserved or diagnosed with preserved ejection fraction. So some of the things that you can see also on an echo, like when you're actually seeing one, so if you guys are able to shadow cardiology, that's really the biggest place that you would ever see echoes being done routinely. They'll do them in the clinic office. But you can see some hyperkinesis, which means the walls are contracting too much. So we know that kinesis is movement, hypo, we know those, what's the word called? Y'all not gonna help me? Okay. The beginning of a word. Yeah, there we go, thank you. We know what those prefixes mean. Hypokinesis, the walls contract too weakly or too slow. Akinesis, so they're not contracting at all, so the physician can look on the echocardiogram and not see any movement. And then dyskinesis, which is abnormal movement of the walls. They'll also examine the valves. So we mentioned earlier, I've talked about the tricuspid valves and how you can hear the S3 and S4 sound sometimes if something's going on with those valves, if they're not opening and closing properly. They can see that on the echocardiogram, and then they'll look for structural heart defects on that as well. And so that's not something that you guys will routinely have to examine and determine what it is, but you will routinely look at a patient's chart and see ejection fraction of 35. Patient has hypokinesis in this area of the heart, and so it's important for you to understand what the test is that was able to diagnose that or find that out, and then kind of what those structural defects mean for the patient in terms of heart failure or AFib or whatever the case may be. So just being able to understand and recognize that was really just the purpose of this slide. So any questions about echocardiogram that I might be able to answer? Dr. Snella may have or may go into more detail about it. I don't know what you guys' schedule is. I'm sorry, I always ask, haven't had this very much, but she may go into more detail about that. All right, and then I just put a picture here for the break. So normal, you can see here this open space, and then here on the abnormal one, there's some fluid or something happening here because the space is closed or narrowed, and there's an obstruction in the heart there. So that's kind of what you would be looking at on an echocardiogram. We've all seen those before. All right, questions? All right, let's take a quick break, and then when we come back, we'll do our 2 patient cases, and then we'll be done for the day.
If you show me that, I'll be looking for the head, the legs, the arms.
Yeah. What are the subgroups of pulmonary artery hypertension?
Okay, I saw you right
Hey Lindsay, do you know what the major subgroups are that he was talking about in the objectives of pulmonary artery hypertension?
Oh, no. That's the part I haven't read yet.
I don't get that.
I started from the bottom and went back. I
Oh,
watched all the videos, I read all the material for what's her name and copied it down.
because there's this thing called functional classes, which are like, oh, wait, oh man, I actually don't know what those are. There's too much reading. Oh, it's kind of like Wood Wallace, like slight limitation, more limitation, no limitation. I don't know if those are subgroups or if in one of his readings it lists literally so like all of these. I don't consider these subgroups because let me see. There's 7 per disease state, yeah. Nope. Nina, did you read for today? Do you know?
Doing the drugs because I know that's for sure.
Same, yeah. That's what I focused on. I read. Yeah, as for reading the chapter, that's what I'm doing during class today. Or at least skimming through it.
Oh, what?
If you don't have a test, you do a fasting.
Oh, I
Is
see.
there a rat? So that I need to download? I mean, I know it's the mid quiz, yeah. If they don't quiz us on this mess, I'm gonna be so pissed off. Because I spent so much time trying to prepare for this. And tomorrow we've got 50 pages of Dr. Coleman.
Oh, well. Somehow I can read law fast, but some things I can't.
I can't comprehend it. I mean, I can skim through it.
Yeah, but
I think I found the subgroups that he was talking about. There's so many of them. Apparently, pulmonary hypertension is like kind of like CAD was like a big thing, and then there were smaller things under that. So like the big thing would be pulmonary hypertension, but a specific thing would be pulmonary arterial hypertension.
You got it.
Oh, okay.
And that's all I know.
Is it a write-up for the class today?
Hmm?
At this
Oh,
point, there's no point in giving them because none of this is specific teachable. And
Yeah, that's true. They're not going to quiz us over it on the test. Or, that's true. They stopped assessing our readiness a long time ago.
yeah, there is no getting ready. We just walk into it.
Is it the meds quiz? So
Yeah, that's up. I downloaded it this morning.
how much do we have left on break? Do you think? You know what time when you went out?
I didn't look at my clock.
I was gonna go get a snack, but I probably shouldn't.
At around 15 after. So, like 6 minutes. So, 'cause I sent a text right when we was gone.
Oh, there's time.
Holy cow. Oh, Matt Lauer is on Facebook. Matt Lauer on was it ABC?
I was talking about him on the radio.
Huh?
They're talking about him on the radio.
I mean, yeah, it's all over the place.
What did he do?
Apparently, this inappropriate sexual behavior in the workplace, and he got fired immediately.
Let me see what he looks like.
It's
Which man it is. I don't remember nobody's name.
it's here.
Yeah, that's him. You know, like, these fucking men, like, saying,
was that he got fired like overnight. Like it wasn't someone came out. This was 30 years ago. Like it happened this morning and he was removed. See, it was in.
Like he did something, like say today, and then he got fired, or he did something.
No, he did something today.
Chairman Andy Mack said the following news to our organization. On Monday night, we received a detailed complaint from a colleague about inappropriate sexual behavior in the workplace by Matt Lauer. It represented after the violation of our standards. We have decided to terminate his employment. Although it's the first complaint about his behavior in the over 20 years he has been an NBC. We're also presenting the reasons why this may not have been an isolated incident. Our highest priority is to create a workplace environment where everyone feels safe and protected, and to ensure that any action that run counter to our consequences. Complaints submitted by Mr. Roberts placing together an organization and is transparent in a manner that's been handled as a statement from our charity. And just like this, moments ago, just this morning, as I'm sure you can imagine, we are devastated. We're still processing this. And I will tell you right now, no more than what I just shared with you. We're covering the story as reporters, as journalists. I'm sure we
I just feel like at this point, if a man brushed you by accident, they just,
Well, see,
they not ever gonna get the details. But what happened?
well, see, that's what makes me think that something like it was probably pretty significant because I mean they fired his ass
Immediately.
immediately. It wasn't one of those things. Oh, well, we're looking into it. Oh, this happened. There's this big light. Apparently, it's not the first time he's cheated on his wife. I don't know.
I've started
Can't fix it.
I just wanted to make sure. Listen, I've heard now that you
All right, so we're gonna do two things in addition to our well, one is our cases, and then the other, I want you guys to walk through all of the physical assessment. So if you were to come into an OSCE or a skills exam and your prompt says, Mr. Joe is coming into the clinic today and complaining of edema and difficulty breathing, please perform a full cardiac assessment on this patient. You would start off by greeting the patient, letting them know who you are, of course, and then telling them, I noticed that you're having some difficulty breathing and some edema. Do you mind if I do an exam on you? It should take about 5 minutes. And then from there, you start with your heart rate, your respiratory rate, have the patient lean forward, check their breath sounds on all fields, have the patient sit back, check their heart rate, check the patient for any peripheral edema that they're having bilaterally, and then check for skin Turgor and capillary refill. So work through that, take about 15 minutes because it shouldn't take more than 5 minutes per person. I just want you to get used to working through the series of the entire exam that you would have to do for a skills exam or OSCE. And then after that, we'll do our case, and then that'll be it for today, okay? And I'll be walking around if you have questions. And I know it may be a little hard to hear, sorry, in this room with everybody doing it, but just do the best you can for right now.
stethoscope too hard.
Don't forget that. I mean, that's all about like.
Already. We gotta do the whole thing.
Oh wow.
We gotta follow this.
I'll just walk up the flight of stairs. So.
Oh, it's alright. Hi, my name's Alex Maldonado. I'm a pharmacist.
Hello.
I hear you have some problems with breathing and some edema. That was in there.
Yeah.
That was, okay.
That's why I'm here.
I'd
Yeah.
like to do an exam on you if you don't mind.
That's fine.
Just to assess the trouble breathing and edema.
That'd be good as long as I can figure out what's going on with me.
Okay. So first I'm gonna check your heart rate and respiration rate.
Okay.
So if you just put your hand up here, just relax a little bit.
Back to you.
Do my respiratory?
12.
Sneaky,
Sneaky. I wasn't looking though. I was looking down.
48 times 2, 96. Yeah, you came up to say
Yeah, it came up a little bit.
from 88 to 96.
Yeah, power walked over here.
Okay, now I'm going to go ahead and listen to your lungs and
Okay.
listen to your heartbeat. So if you just sit up straight for me, slightly lean forward. I'm warming it up, so it's not cold. Take a deep breath.
That nigga don't work.
Yeah, both extremities are edema. But as for skin turgor, I don't really think it matters.
You can go ahead and face me and I'll check your heart. Listen to your heart.
You know how to document? He would be given a page that was like this. So you would say normal.
92, 14. What was CD?
It's positive, that's one, it's 2 minus, it's 3, 4 is how you document CTAB. And extremities is where we would go with the 0 plus. And then slash, how do you document TT? Skin refill, and you have the capillary refill. What is capillary refill? Extremities? Yeah.
Yes.
Capillary refill is 2 seconds. That's one. And then you would say,
Skin, normal skin.
at back of hand. You have to put the location. At back of hand. At something, whatever this is. For. Yeah. You good.
Lungs sound clear. Have a normal heart rate.
Get my friend.
I'm just taking everybody's respiratory right now. Because that's what I struggle with. Are you not
Did you hear anything in that high pitch sound?
No.
So what is it?
I feel like I've never had an issue with my heart.
Yeah, a patient, an in-town patient.
Oh, it
To
is.
practice home.
Okay. Sorry. You're talking about you were going home. I mean, like,
Okay.
Should have been fake wheezing or something? Where you're like,
I'm not sure you can.
I can't remember the name.
We'll try
yeah, that's
later.
interesting. If I could do it.
Hey, can you go ahead and extend your arms out for me? Keep them at the level of your heart. I'm just gonna depress your thumbnail, thumb
I
bed.
didn't know. Alex taught me how to make
My hand
it.
is kind of cold. Let's hold them up on
I got to pop this out. And
Let's see.
in the book, sometimes they tell you to press the center and pop this out. So I couldn't get it out.
Yes, it is.
Okay, and then I'm gonna pinch your skin just slightly.
Alex taught me how to get it. Okay. You want to listen? You want to go through it or you want
she's going to do it on me.
Now, if you just go ahead and roll, lift your panel a second.
If you need a patient, I mean,
I better try to check this out.
yeah, do it on me.
Once your pair has finished going, each person come up and grab the case, please.
Is that enough meat?
Yes. Heart rate, respiratory rate, lung exam.
Yes. Oh, yeah.
Lung exam. Then you do the heart. Then you do the edema. Then you do your skin turgor. And you do your capillary refill. It's just the list that she gave me. That she was talking a second ago.
You did your 10 That's what it is, yes.
Alright, checks that out good. Oh, I forgot to tell you to disrobe to the waist.
No one worded it
Oh.
hard.
I warmed up the
I
stethoscope.
mean, in the picture it shows the sternum
Yeah.
here,
They're like that.
and you go like right side of the sternum,
Rotate you
left
bell.
side of the sternum,
And then down
and
along
straight
the spine.
down.
Is it down along the sternum?
Yeah. Well, the dots show here. I wrote it down. So the dots show. So this is going to be right side, left side.
Okay.
So right side, just to the right of the sternum.
I'm giving you guys two cases. So for the first case, one person will be the patient, use the patient direction,
4.
and the other person will use the pharmacist, and then you guys will switch for the second case. No, that's for you and your father.
I like this picture more.
You know, one of those diagrams or those mannequins. Yep. So that way I can look and I can picture, okay, this is you. Here's, and then I remember the body, and this is where I need to go.
I was basically asking.
like this picture. This is a pretty good one.
No.
Like this shows you where you would do all the sounds on someone.
Yeah, but I'm not
It's a little
following
better.
this. Look, it says cardiac auscultation. Right sternal, yeah. Left sternal.
Yeah.
And then auscultation, you go back up.
Intercostal space.
You go back up with the bell. Where does it talk about the lungs? Oh, okay. I thought it'd be somewhere up here. Check 2 areas, I did that. Press down, did that. I documented the heart rate, I didn't do that.
Documentary.
Beats per minute. And breaths per minute.
What was that? That was from yesterday.
No murmurs, rubs, gallops, regular rate rhythm. Clear to auscultation bilaterally. No rails, bronchi, or wheezing.
I don't know what you say on this for just negative and
0 plus spitting. 0 hitting.
oh yeah. And normal skin turn. Oh yeah, I was probably on all the wrong spots earlier. Now I can kind of see. This image is really way better.
Yeah, so this is on the right side of
Yeah,
the
your
sternum.
sternum's there.
You were more in the middle.
Yeah, I see what's going on now. And I was kind of on the outside of it. Hello, power.
Are you guys on the case already?
Okay, so do you want to just save time on the
Yeah.
heart rate and all that? I'll just do the one sound and all that.
Heart?
I'll do the one sound
Greater than 40 is preserved. So this is reduced. So this is histology.
Stage 6, so we would give
ACE inhibitor.
beta blocker and boost diabetic.
Yeah.
Yeah, you'll-
I did it wrong.
No, I'll do the heart sound.
So she's on ACE. She's on beta blocker.
Stage 6 means they get a loop.
ACE.
A.
Get a beta blocker.
She's on the statin. There's the beta. And then that's the cholesterol. Okay. Okay.
Based on information, some additional
Good.
Yeah, I shouldn't hear anything that's
how
No,
often
no.
but I was going back up. But yeah, I heard all that.
I never miss my
That was
bed.
way better to use that picture.
You want to grab the case?
I never miss them. Is the and what else? What else do you want to know?
Are these extra?
This is the second case.
Okay.
Who's in it?
How long? Does that make a difference?
It's a nice chairs.
I know. All the tables are spread out.
Yeah, they're really close together.
They almost have meetings in here.
Patient info, pharmacist. It's gonna be patient or pharmacist.
That don't matter.
This is this info.
Are these the same questions as that?
Based on, yeah.
Okay.
Yeah, they are. So you want to see again.
They're on medium right now. Is it medium? So the question is, do we change
The patient includes your clinic presents some medication of medical and suspect medication adjustment
Okay, so you don't know much about.
That's why I think spell check and always abbreviate something.
You get in the character. Just be a 65-year-old lady.
Turbo. Whatever. Increase to 40 to 80. 40.
What about you want to change it to target dose?
They're not at target dose.
Counseling group, right?
I'd say bump it up.
What is it?
They changed the counseling group, right? So this is kind of strange.
Staff, we need to live with
Oh, just see.
They say what brings you in today.
that. What type of follow-up is that?
Okay. So, Jane,
We got it.
how can we help you?
I've been having trouble sleeping lately. I've been getting up every night to sit on my recliner, or I'll prop myself up in bed. And so when I prop myself up, I'm using 3 pillows.
Okay.
Yeah, but I've just been having a lot of trouble sleeping.
Let's see. How long have you been feeling like this?
Does she have? Do we know? Does she have?
I started noticing it about 2 weeks ago.
Yeah, formal.
So you are able to sleep, but with 3 pillows sitting up.
Do we have to specify fasting?
What's
Or
it?
what makes it? What makes it?
I've been having trouble sleeping, so I haven't been sleeping.
Oh,
good.
you haven't been trouble
Yeah, I have not been
Okay,
sleeping good.
I guess I don't need to ask you what medication. Have you been taking your medications as directed?
I take lisinopril for my blood pressure. Oh, never mind. I never miss my meds.
Never miss your meds?
You could just do a full verdict. Just to encompass everything.
I answered the wrong question.
Right.
I'm sorry?
I was answering the wrong question. Like,
Do you have any drug allergies?
no. No known drug allergy. If the patient ever says to me, I'd be like, what?
Okay, are you having any trouble with the medications you're currently taking as far as any side effects that you think come from the medications?
No, I've been taking these medications for a little while now, so, and I haven't noticed anything.
Okay.
Yes, I think so. Definitely.
What else do you have going on other than heart failure?
Oh yeah, sodium restriction.
Or do you know why you
okay.
take? Okay.
I got high blood pressure, high cholesterol, and I have heart problems.
Okay.
And to answer your question about do I know why I'm taking those, is I take my lisinopril for my blood pressure,
Okay.
atorvastatin for my cholesterol. I take a water pill and metoprolol. I'm not sure what those are for. Maybe it didn't say, but sometimes I take aspirin when I remember. Yeah, so it seems like they kind of don't really know why they're taking the water pill and metoprolol.
Are you having any trouble as far as like swelling in your extremities? I guess I would do an exam.
That's a good question.
I'm not gonna go to another exam.
The only thing it says here is I kind of have a history of heart problems and high cholesterol and high blood pressure and all that.
Okay.
And then yeah, I guess there's no edema, but they wouldn't know, I guess.
Yeah.
There's no swelling. It didn't say anything about swelling.
What are the symptoms? I don't know.
So it's like location of symptoms.
Yeah, so you might
I
ask.
just noticed it with my lungs.
I noticed
But
you're due
wait,
for some refills.
but what's
trouble
the?
sleeping?
Yeah.
But how does the trouble sleeping connect to
Okay,
the
so you need to
lungs?
ask
I don't
where
know.
have you been
You know, that's what gets me. Like, how would you have known to?
So, any trouble? Are you having trouble breathing? Obviously.
Yeah,
Okay.
you think that would be a question
Trouble
here,
breathing.
but it's not a question. But
Trouble breathing and sleeping.
oh, here we go. Short of breath anytime I lay flat. So that technically should have been part of the complaint,
Yeah.
maybe, but I guess
I guess it's part of what's trying to dig out information from you.
it'd be like, hey, if you have any problems breathing, shortness of breath, that is kind of common in heart failure. Since we're assessing
Any
heart
other
failure.
symptoms you have?
I guess you could
That was
ask
the
That was the other-
that was the other one. But that's also the
about
kind of the main
medication
one,
routine. Are you
really.
using anything to help you remember anything? I mean, I don't feel like that's
Yeah, and he said that because it says location of symptoms, I just noticed it with my lungs, hard to breathe, I can't sleep. I guess anytime I lay flat, that would be the additional one. Just the fact that every time I lay down, I can't breathe, but when I prop myself up, I can a little bit. It helps me breathe to where I go to sleep. Yeah, I can't sleep anymore unless I sit up. It happened about 2 weeks ago.
You could say,
You know, oh, so it's not just at night. Also, it's also when, even during the day, if I try to lay down, take a nap or something, I'll still be short of breath.
I guess utilizing a method to give medications, or I don't know how you phrase it.
So, based on the information, what are some additional questions you might consider asking?
Or medication adherence.
Any chest pain? Chest pain. I want to know if they got some chest pain.
Yeah.
And like you said, I guess that was an additional question. The edema. Have you noticed any swelling in your feet?
Look if your shoes still fit you.
They're like, oh, I just thought my feet were growing. You'd be surprised. I could see someone saying that.
Bed adherence.
I must have struck my shoes the other day when it rained. Or
Sometimes when I
something
take
stupid.
aspirin, when I
Gut allergies,
remember, I don't know.
PMH, high cholesterol,
Exercise?
what makes it better was pass out.
Yeah.
Only when I lay down in bed.
Yeah, I
Usually
kind
I don't
of.
use pillows. I've been using them lately. Sitting up in my recliner and using the pillows. So, told me that. I asked about any other side effects.
I was asking if they've ever
Are
had
you
a
guys still
stent
working on case 1?
or anything like that.
Yeah, we'll start.
Okay, well, you can do this.
Since you're water bag, you mostly eat organic foods. You might be
Oh.
there. Well, this is a girl.
Wait. Hmm? Yeah.
Okay. I guess we can do that now. Do any changes need to be considered? Probably make aspirin mandatory.
Was it PRN?
It's not even on here.
Oh, wow.
But I don't know the target doses. have to pull up that chart.
Yeah, you're good.
Yeah, target doses.
So my ejection fraction is pretty low. Kind of confused on where to go with this.
Follow-up labs and vitals need to be considered. Serum creatinine,
Yep.
potassium, I think was one. Magnesium.
There we go.
What's that?
All these.
CBC. Why CBC?
Since anemia can exacerbate heart failure, apparently.
Anemia.
That's a good little point. I didn't know. I mean, if you have a low blood count,
Yeah.
you have less blood to pump.
Since he
Serum
That's for
electrolytes and creatine.
no undiuretic dosing. Oh yeah, you don't know.
so how often
I don't think I'm diabetic, but
at least
oh, I also smoke a half a pack of cigarettes a day, and that kind of that's not in these questions, but it's kind of up there.
Okay, well that is being non-foreign.
Yeah.
Smoking cessation.
And diet.
Cessation. Diet.
I don't know about exercise. It doesn't really say.
Well, 65, right? Maybe exercise.
I don't think I take over-the-counter medicine, but you can ask that. Heredity
All right, let's talk about this
hemochromatosis.
case, the first case real quick.
I don't think it's just
Okay, so
Maybe a BNP.
Yeah.
all right, so if you look at the pharmacist direction sheet, we have a pharmacist who's working in a primary care clinic. The patient is new to the clinic and presents for medication therapy management. So you assess the patient's medications, address any concerns, and perform and document a physical assessment. Ask the necessary patient assessment questions and then determine what additional questions need to be asked. And so we had one person play the pharmacist, the other played the patient. And this patient had a past medical history of hypertension, dyslipidemia, and HFrEF stage C with an ejection fraction between 30 and 35%. 65-year-old white female. And then her medications are listed there. Last fill date should be 2017, but I forgot to change it from last year. So, and you could have counted on adherence, or could have imagined 17 there. That's my bad. I'll change it for tomorrow. And then the social history, negative for alcohol and positive for 1.5 packs per day of cigarettes. So for this patient, or for this component of class, I guess I should start with, in your notes, I have some information about subjective questions to ask when you're assessing and identifying the control of a patient's heart failure, and then when you're assessing for additional risk factors. And so make sure that you go through those questions and understand what the types of things are that you need to ask patients in a true assessment scenario. And then I've also uploaded these cases on Canvas so that you can kind of see both perspectives from what the patient should expect you to ask and how to answer those questions. And that's kind of walking through, I don't know if you guys learned PQRST or what mnemonic you were given as far as asking those. What are the relieving, what are the remitting factors, things like that. So make sure that you ask all those questions to find out what the patient's control is of the heart failure. Also, you want to make sure that you assess the patient's medication list. So that's something that we do for every patient every time is medication reconciliation. So are there any medications on the list that are not adequately dosed or not appropriate, do not have appropriate regimens that interact with other medications? Are there medications that this patient should be on that they are not on? And are there medications that could exacerbate or precipitate this patient's current medical conditions? So those are some of the things that you have to look out for. And then also monitoring. So when I was going through you guys' SOAP notes, some teams did really well and some teams didn't mention it at all. So I don't know where the disconnect was. But when we talk about monitoring, not only do you monitor for those subjective things like patients with signs and symptoms of bleeding. So a patient may say they're bruising or something, but you also have to check for those objective measures. So if you saw my notes, I may have put on some people's SOAP notes. What about the serum creatinine? What about the CBC? What are their hematocrit and platelet counts? So don't forget to ask and look for those objective measures of control as well. Most people in here start that patient on lisinopril. We can't just start lisinopril and not follow up with serum creatinine, BUN, and potassium level because they could those levels could get out of hand. So you need to make sure that you're explicit about monitoring for those types of things as well. All right, so in terms of answering the questions for this particular patient case, based on the information that you obtained, what are some of the additional questions that the pharmacist might consider asking? Just shout some stuff out at me. What'd you guys write down? Smoking. Are you interested in smoking cessation? What strength of aspirin do you take and how often are you taking it? If he's ever had a heart attack. So he's looking for previous cardiovascular events. Have you ever had a heart attack?
How long the chest pain lasts?
How long has the shortness of breath been going on?
How long the pain lasts?
And then how long does the pain last? Okay. Surgical procedures. I'm sorry, I keep reminding you. Any other questions? Want to find out about family history?
How willing are you to quit smoking?
So yeah, how willing are you to quit smoking? So just assessing that smoking cessation component. So why are they not taking one medication versus the other? So what are the barriers to adherence there for one thing over another? What else? So therapeutic lifestyle changes, so diet and exercise. How much are you exercising, or do you exercise? What does your diet look like? And for me, when I see patients, I ask them, what did you have for breakfast this morning? Or what did you have for breakfast yesterday? What did you have for lunch today? Or what did you have for dinner last night? So that I kind of get a true picture of what they're actually eating. Because if you ask somebody, how's your diet? Oh, it's pretty good. You know, I mean, that's just kind of a super open-ended question. So just trying to be specific with patients to find out what exactly they're eating for each meal. And some patients will tell you, like, for my diet, if somebody were to ask me that today, I would be like, well, Thanksgiving just happened, so that was a bit abnormal, but typically this is what I do, so just find out specifically what the patient does for diet and physical activity. What else? What's something that we want to ask to find out if they are having edema, fluctuating edema, or stable edema? Huh? Weight changes. So are you checking your weight daily? If so, have you noticed any changes in your weight? If they're not, recommend that they do daily weights. Wake up in the morning, urinate, check your weight. And that's important for patients with heart failure. Back to diet. So we asked about diet. Try to specifically hone in on the sodium component of that because we know that's a big issue. Did anybody ask how many pillows they sleep on at night?
I just kind of told you.
So ask about that. I think this patient was having issues breathing, right? And they may be noticing some shortness of breath when lying flat. So ask about that. And then, as I mentioned in class, a lot of times people will have 2-pillow orthopnea, 3-pillow orthopnea, and that's something that we document as such. All right, so do any changes need to be considered with the current medication regimen? Are the doses adequate? So she wants to increase the intensity of the atorvastatin. Change the dose of the beta blocker, increase it. What else? Yes, so furosemide, that was the big one for me. If the patient is still having some peripheral edema, you either need to increase the dose of the furosemide and frequency, or you could do what? Add, spironolactone to an aldosterone antagonist, something like that. So increase the dose of furosemide is probably the most common thing that would happen, but you could also add aldosterone. Is the patient on any medications that may exacerbate heart failure? No, looks good. All right, what types of labs and vitals need to be considered? So what labs would you ask for on this patient? Blood pressure, serum creatinine, CBC. You say LFTs? LFTs, patients on statin therapy. What else? Lipid panel to assess, depends on how long it's been. What else?
Hemoglobin A1C.
So, yeah, all that's in the CBC, so you'll get the hemoglobin, platelets, and hematocrit. So we just got an ejection fraction, but follow-up ejection fraction, follow-up echo. The only other thing I have is O2 stat, just to double check and see where the patient is if they're 90 or above. All right, and the last question, what non-pharmacological counseling points would you want to include? So we've already said smoking cessation. We said most of these actually that I have. So what are the ones? Diet, especially sodium restriction, water restriction. Counsel on the timing and the dose of the diuretic. So medication adherence and medication counseling is going to be huge. And then the daily weights, which we mentioned that also. All right, does anybody have questions about working through this case? All right, so this was just an example of from start to finish. So make sure that when you're studying for the exam or studying for your OSCEs that you go through these notes. The beginning of the notes is really just a review kind of heart failure. Last year when I taught this, they had not had heart failure yet, so that was difficult for me. So that was me giving them a kind of a snippet into it. So for you guys, it's kind of a review because you had it. And then the second part of the notes, the assessment, monitoring, and follow-up. That's really the biggest part that you need to focus on for the laboratory component of this class and for the test and for any physical assessments, skills assessments, and OSCEs, okay? So if you have questions, let me know. There's a second case that some of you got, some groups did not get it, but it's up on Canvas as well. So as you're preparing, that's something that you can utilize to practice and role play with your partners on as well. All right, any last minute questions? All right, you guys can go. All right, let's see. The PowerPoint should be posted. Do you guys not see it? Does anybody see the PowerPoint on Canvas? Huh? Yeah, it should. It's a PDF. Okay.
You need to work through your second case though. Put the other one in the box. I really don't want to come to class today. If you wasn't on account for that.
Any quiz?
Let me lay his computer down. Let me see you put this in there. I'm trying to see if you put this back in that box. I can't get mine back in the box.
That's the printing center.
Okay.